is Melissa Hidalgo, internal medicine resident physician at Broward Health, North Campus. Today I'm going to present a case about thyroid dysfunction due to amiodarone use contributing to decompensated heart failure. Thyroid dysfunction hypothyroidism has been associated with decreased cardiac output by 30 to 50%, decreased cardiac contractility, corrected QTc interval prolongation, and increased systemic vascular resistance. Amiodarone is an effective antiarrhythmic agent through calcium and beta-adrenergic properties and sodium and potassium channel blockade. However, amiodarone has a structural similarity to T3, which can lead to a thyroid dysfunction condition at systemic and cardiac tissue levels, affecting 14 to 80% of amiodarone-treated patients. Here we present a case of decompensated heart failure in a patient with chronic amiodarone use with new onset thyroid dysfunction. Here we have a 77-year-old female who immigrated from Brazil a few years ago with medical history of heart failure with unknown ejection fraction, paroxysmal AFib on amiodarone and apixaban, who presented with worsening dyspnea and substernal, non-radiating, sharp chest pain that started a month prior to admission. Associated symptoms were orthopnea and bilateral leg swelling. Symptoms were exacerbated by exertion, relieved by rest, and she reported compliance with medications. On admission, EKG shows sinus rhythm, ventricular rate of 63, left axis deviation, LVH, QTc was 491 with no acute ischemic changes. Blood pressure was 194/99, respiratory rate 25, and other vital signs were unrevealing. On physical examination, there was JVD, S1, S2 present, regular rate and rhythm, systolic murmur at the apex, hepatojugular reflux, wells in lung fields bilaterally, and lower extremity pain edema 2+ were noted. Labs were significant for BUN of 40, creatinine level of 1.6 with unknown baseline, brain natriuretic peptide 1400s, troponin level 0.04, followed by 0.06 and 0.06. TSH level was 109.90, free T4 0.65, with no baseline thyroid function levels. On imaging, chest x-ray showed cardiac enlargement with pulmonary venous congestion. Patient got left and right cardiac cath and transthoracic echocardiogram, which demonstrated moderate dilated left ventricle, moderate concentric LVH, left atrium severely dilated, moderate to severe aortic stenosis and regurg, moderate to severe mitral stenosis. Ejection fraction was 40 to 45%, elevated pulmonary artery pressures, and minimal ischemic disease. Patient was evaluated by cardiovascular surgeon. She was deemed a poor surgical candidate for any cardiovascular surgical intervention. Patient received IV diuresis and was started on levothyroxine 50 mcg per day, after which she was medically stable for discharge with a plan to follow up with cardiologist as outpatient. Patients with heart failure and hypothyroidism or subclinical hypothyroidism have an increased risk of hospitalization and all-cause mortality, even after correction with thyroid replacement therapy. Although amiodarone-induced thyroid disease is not a fatal complication, it could lead to endocrine emergencies, such as myxedema coma. In amiodarone-treated patients, close follow-up of thyroid function is essential to avoid emergencies, usually every 6 months. Further research is needed on dosing strategies to guide thyroid hormone replacement in amiodarone-treated patients who develop hypothyroidism, with the ultimate goal to reduce morbidity and mortality. Thank you everyone for your time, and have a great day.